Good evening, everyone. First of all, on behalf of Walter Slover, a warm welcome to all our speakers and attendees of this webinar under our Medical Age series. Our topic today is prenatal screening and diagnosis of birth defects. Also, we'll be taking all the questions at the end of the webinar, and I request you to please post all your questions in the Q&A panel of this event. We'll try to address the maximum questions at the end. We'll also provide you the link to give your feedback of the webinar, which you'll post in the chat section. Our moderator and the speaker today, I'll introduce Dr. Renu Mishra here. Dr. Renu Mishra, who is Senior Consultant, Obstetrics and Gynecology, Sitaram Bharatiya Institute of Sciences and Research, New Delhi. Now I request Dr. Renu to please introduce our speakers as well as the topic for today.
Thank you, Ravi. Can you please make me the host?
Yes, ma'am. Yes. Ma'am is there. You can present it.
Good evening, everybody. First of all, I would like to welcome all of you, those who have logged in today for our virtual seminar or webinar on prenatal diagnosis and screening. I have the pleasure to have with me today two of the most eminent faculties. I wouldn't say famous, because anybody can be famous even for the wrong reasons. They're the most professionally competent people, and I can vouch for that personally. So we are lucky to have them with us today to talk about prenatal screening and diagnosis of birth defects. I would introduce the first speaker first, Dr. Asha Ritsinghani. She has been kind enough to get up very early for us and logging in from Seattle. It's only 6:30 in the morning for her. Dr. Asha Ritsinghani has a very long CV, but I'm going to make a crisp, small introduction. So she is professor of maternal fetal medicine. She is currently working at University of Washington, Seattle. She's also professor at University of Iowa. She did her fellowship in maternal fetal medicine at Johns Hopkins Hospital and in immunology also from University of Iowa. She's a faculty at Johns Hopkins, University of Iowa, Albany Medical Center, New York, and University of Washington. She is also the National Officer for Society of Maternal and Fetal Medicine. And oh my God, she has got such a long list of honors and awards. But I would like to highlight some, I'm really impressed that she has got so many awards for Teacher of the Year, which was given by University of Iowa. Then the Teacher of Award, she has been receiving for many, many years actually. Nominated as Asian Person of the Year for the state of Iowa. And she's been getting the award for many years as Best Doctors of America, 2013, 14, 19, 20. What about 21, Asha? I'm sure you're going to get it again. So I think I would not be standing in between you and Dr. Asha, and allow her to share her screen so that she can speak to us. She will be speaking on biochemical screening and maybe some invasive testing. And Dr. Ashok Khurana would be then speaking on the reproductive ultrasound. So I would unshare my screen, and I can stop sharing. How do I stop sharing? Stop sharing. Okay. And can you, Ravi, make her a host? No, I'm just going to stop sharing. Okay. Right. So I've stopped sharing. And if you could make her the
Dr.
host.
Asha, you cannot present the screen, ma'am.
Okay. So I want to welcome everyone to this webinar. I'm really, Renu is a very dear friend, and I love her. She's like my most favorite person. And it's so nice when she told me to do it. The answer, of course, is yes. And I'm hoping, I know some of you people through the OBGYN discussion group. It's always very nice to meet here on the, if not in person, at least we can meet online, and hopefully one day we'll meet in person, hopefully within a year or so. So I'm going to go real fast, and I have a request. So this is really important. The request is, do not take any notes. Do not take any notes because this is my email. Please write it down. If you email me, I will send you my PowerPoint. But if you make notes, you're going to miss a lot of what I'm saying. And the thing is, the cytogenetics field is racing so fast, even I have a hard time keeping up. So if you take notes, you're going to miss what I'm going to say. So this is my email, and I'll have my email again at the end of the talk. So the points, if you are going to fall asleep after this next two slides, it's going to be okay, because these are the two most important slides, and I will repeat these slides at the end. Who should be offered? The point to remember is everybody should be offered screening test and diagnostic test. At least in the USA, we offer even a 22-year-old, if she wants to have an amnio, diagnostic amnio, we will offer it to her. So diagnostic means you put the needle in, screening means mother's blood or ultrasound. So there are a wide variety of tests available, and each one has its advantages and each one has its disadvantages and limitations. And therefore, you're going to pick and choose. Well, you are not going to pick and choose. Patient is going to pick and choose. You may help her if she doesn't understand, but so many different ones, and she should take the one that is best for her. So you can do it in the first trimester. You must, the other thing important, and I see this question asked a lot of times, if you have done a screen in the first trimester and it's positive for higher risk for Down syndrome, should you do a second trimester screen? Absolutely not. One screen should not be followed by a second screen. And so everybody with a positive screen should undergo counseling and a detailed ultrasound exam. And Dr. Khurana will go through the detailed ultrasound examination with you. But this is very important. Do not offer them the triple or the quadruple test. Importantly, if the tests are negative, your screening test, even amniocentesis tests, if they are negative, it does not rule out all the genetic defects, because literally there are thousands of genetic defects and there's no way on earth you can rule all of them out. So don't tell the patient 100%. Always tell them 99.9%, even if you're doing an amnio. So the one thing you can do for non-invasive testing is, if your first trimester screen is positive for increased risk for Down syndrome, or your quadruple screen is positive, you can still offer cell-free DNA, also known as NIPT, but you will have to let them know that this is also a screening test and that it does not 100% rule out the condition. But if the patient absolutely doesn't want an amniocentesis and wants an NIPT, NIPT is a far better test than the blood tests for hormonal levels, the first trimester and the quad screen, because here the answer is yes, no, very high risk, very low risk. Whereas the quad and the first trimester double screen, it just gives you a number. Her risk is 1 in 180, her risk is 1 in 280, 250, 300, 1 in 3000, like that. But cell-free DNA says very highly likely baby has it, or no, highly unlikely. The other thing is, if you see a baby with an abnormality, a physical abnormality or an increased nuchal translucency, they should be offered the diagnostic test, the CVS and the amnio. Why? Because it's not just chromosomes. So many different things can cause increased NT. The NIPT mainly looks for chromosomes only. So you will offer them diagnostic testing if the baby has a physical issue or the NT is increased. Of course, there are second trimester positive ultrasound markers. And if the patient has come late, you can do an ultrasound and you can do the quadruple screen if the first trimester screen is not done. And remember, the accuracy in twins is a little bit lower. It's getting better, but it's a little bit lower. And finally, so many people in India are going through IVF, and I don't know how frequently they're getting the PGD, which is, before the embryo is put into the mom, they take a cell from the embryo and they do pre-implantation genetic diagnosis, and only if the embryo is good, they'll put it in the mom. So even if they do that pre-implantation genetic diagnosis, it does not 100% rule out. In fact, I believe there's like a 4% or so chance that they'll even miss a chromosomal abnormality. So all PGD patients must be offered the option, even if they've had it before. So what are the options? And I'm going to race through this because I have only 20 minutes and I think I've already spent 5 minutes. So what are the options? You can do ultrasound only, blood test only, ultrasound plus blood test. Some of my patients refuse blood tests. They are very happy. If everything is fine, the NT is normal, the baby is normal, she's 25, her risk is low, she'll say, thank you, goodbye, and she leaves and comes back at 20 weeks for a detailed exam. You can also, or you should also offer diagnostic tests, CVS, amniocentesis. And the reason being, just so you know, karyotype detects abnormalities only that are more than 10 megabases, which is 10,000 kilobases. And I'll tell you about this in a minute. And you can do something called microarray. So when you do an amnio or a CVS, you're going to ask for karyotype, but karyotype only looks at big chunks of chromosomes, not little chunks. So if the baby is defective, you want to look at the little chunks that the karyotype is going to miss. That's called chromosomal microarray or CGH. And that will look at smaller chunks, and that will look in kilobases. Look at the size. And the more frequently now we are offering whole exome sequencing. I've been offering it very expensive, but it hasn't been what I thought it was. But whole exome sequencing will check 1% of all the genetic material in the fetal cell. So a quick background. Chromosomal abnormalities occur 1 in 150 live births, all live births irrespective of age. So please keep that in mind. The incidence is greater, of course, when you look at a first trimester. More babies will have it because many of them will abort. As the pregnancy advances, fewer babies will have it. And as the mom gets older, her incidence of having a baby with a chromosome increases. And here it is at age 20. This is a well-published paper. 1 out of 22 pregnancies will have a chromosomal abnormality. At age 25, it's 1 in 90. So at age 22, 1 in 22, at age 35, 1 in 84, not 1 in 90, sorry, 1 in 84. So you can see that they both are at risk. Just because she's 20 doesn't mean she's not at risk. So the most common ones are Klinefelters. I have met Dr. Klinefelter. I will tell you the story if I ever get a chance to. Anyway, next is trisomy 21, Turner syndrome, which is 1 in 2000, trisomy 18, trisomy 13. These are the most common aneuploidies where the entire chromosome is missing or the entire chromosome is extra. Who is at risk? Every pregnancy. It increases if the mother's age is higher. Every pregnancy, that's why it's in such a bold letter. But if mom's age is higher, if the parent is a translocation carrier, I'll talk to you about that in a bit. If a prior pregnancy was affected, abnormal ultrasound, or increased NT or a positive serum screen or NIPT, she's at risk. And as you can see, the T21, T18, T13 goes up with maternal age. Here is a 20-year-old, but this is old stuff. You don't need to remember this because right now, what we believe is every patient is at risk. So here it is. Every patient is at risk. Offer it to every single patient. Let her decide what she wants to do. So who should counsel the patient? Only somebody who has gone through this webinar. So somebody who really knows the basics of genetic screening and diagnostic testing is the one who should be counseling. Because when you get the results, you don't want to say, oh, everybody get it. Like, oh my God, what am I going to do? I don't know what to do with this test result. And then you're busy asking somebody, friends, kya karu, kya karu? No, no, no. Please know how to counsel before you do any test. Do not do a test unless you don't know what to do with the result. So you have to, for the test to be offered, it has to really accurately assess the patient's risk. So it should include the patient. You should have the patient's age factor into it. You should tell her all the limitations, counsel her according to her risks, offer her both, and it should be the patient's choice. I want to just go into basics of cytogenetics because this is really being done a lot even in India. It's being done in India actually for the past, I would say at least over 6-7 years now. So just the basics of cytogenetics. You remember from your medical school days that there are base pairs called TA and CG. And so this is a double-stranded DNA, and these are tiny little base pairs. They are very itsy-bitsy tiny, and C always goes with G, T always goes with A. So here is your chromosome here. It's very huge. and a chunk of it is a gene, depending, some genes are a bigger chunk, some genes are a lower, smaller chunk. And you can see on these chunks, there are so many base pairs. And so any of those are called base pairs. And if you have 1,000 base pair, it's called kilo kbp, kilo base pair. If you're thinking of 1,000,000 base pairs, it's called mbp. So these are the base pairs. So the size of a chromosome, there are 3 billion base pairs or 3,000 million. And in one chromosome, you can have, depending on the size of the chromosome, you can have 300 million base pairs. Total amount of genes, important genes. There are many useless genes, but important genes up to 30,000 very important genes on these 46 chromosomes. And one gene, one single gene, that little pink size I showed you here, it could have as high as 2 million base pairs. So it depends on how big of a chunk this is. If a small chunk makes up a gene, then it has 27,000 base pair, but it can be as big as 2 million base pair. And if you do amniocentesis or CBS, and then, the baby is abnormal, you send off for chromosomes are normal, you can order microarray, chromosomal microarray or CGH, because chromosome analysis, karyotype will look at your entire chromosomes, or if half of it is missing, or like a huge chunk is missing. But chromosomal microarray will check even as little as 5,000 base pairs. So here is your big fat chromosome, and the chromosome can be abnormal number-wise, such as trisomies, or the structure-wise. So here is the number. You can see this kid has triple something. Maybe this is trisomy 21. Structural, the numbers are fine, just a little chunk is missing. But if a big fat chunk is missing, your karyotype is going to pick it up. It's only the little chunk that's missing. It's beyond the ultra microscopic size, and so your karyotype will not pick up if it's an itsy bitsy tiny little deletion. For that, you need chromosomal microarray or CMA. Here is another example, and here is another. This is a big fat chunk. They should be able to see it if it's such a huge chunk missing. So numerical ones can be aneuploidy, so one extra, hypoploidy, hyperploidy, polyploidy. So this is, you can see that this is all this.
But I don't get.
So many. Sorry. So many hyperploidies, or and this is hyperploidy, where so many of them are extra, and you're like, oh my God, this kid has way too many. It's hyperploidy. This is polyploidy, where many of them are. So there are like 2 sets of maternal and 1 set of paternal, or vice versa. That's polyploidy. Or it's an aneuploidy, where a single one is extra. So that is numerical. What about structural? A piece can be missing, or it could be duplicated, or it could be translocated. And there are many. The deletion is the most common. So you can see this tiny itsy bitsy piece here is deleted. Your regular karyotype will not pick this up. It's too tiny. So you have to do CMA, the microarray. This is a big fat one, and it is duplicated. So karyotype will pick it up. But if it's a tiny one that's duplicated, karyotype will not pick it up. The thing you need to remember is a deletion is far worse than a duplication. This little deletion is the 22q11.2 deletion, which is the DiGeorge syndrome. And so your karyotype will not pick up the DiGeorge syndrome. DiGeorge syndrome is one of the more common cytogenetic causes for cardiac structural defect. So same thing here. This is a translocation. So this is a normal chromosome. This person is also normal. It just translocated. However, when this person has a baby, if this person gives a chromosome, this chromosome, and the father also gives the chromosome, this piece can become extra. That's called balanced translocation. And then there are genetic defects where only one nucleic acid is abnormal. So look at this. This just one single nucleic acid can have an issue. Sickle cell anemia is a single gene, a single nucleotide defect. One single base pair goes crazy, and that person gets sickle anemia. Your karyotype will not pick it up. Your microarray will not pick it up. you have to do a special test for single gene, single nucleotide abnormality, and and they will do that test separately. So if your karyotype is normal, don't tell the patient your baby won't have sickle. Sickle cell cannot be seen on amnios. Of course you can, but you have to do special testing for that because you want to look at the single nucleotide polymorphism. This is a microdeletion, so just a little chunk is missing again, as I showed you. And so anything under 10 megabases, so megabases is 1,000 times more than the kilobases. Anything under 10 megabases, your karyotype will not pick it up. It's called submicroscopic and it has to be tested separately. So if a tiny one is missing, please send off. If your baby is very defective and your karyotype is normal, send off for microarray. So karyotype detects entire chromosomal aneuploidy, polyploidy, some balanced or imbalanced chromosomal arrangements, and if deletions are greater than 10 mega base pairs, large duplication. If you do the SNP base, SNP is single nucleotide polymorphism based microarray, of course, they will see the entire chromosome because they are checking the entire chromosome. They will find unbalanced arrangements. They will also find microdeletions less than 10. So these are more than 10. These are less than 10 million base pairs. Microduplications, triploidy, uniparental disomy, and low-level mosaicism. Uniparental disomy is where in a growing embryo, the two chromosomes, let's say chromosome number 14, both of them are maternal or both of them are paternal. The rest is one maternal, one paternal, but one chromosome, the chromosome, both of them belong to the one parent. And so that patient, that baby can have a higher birth defect risk. So, this quickly a history in 1988, we just used to offer second trimester biochemical. And, I was alive in 1988 and doing this type of stuff and learning from there. Nuchal translucency came about in 92, 93. Everybody started doing biochemical testing. 97, we did nuchal translucency and the double screen, as you call it, the first trimester screen. Nasal bone was added some 20 years ago. Cell-free DNA became a routine 10 years ago. And now we are even doing microarray on cell-free DNA, but take it with a grain of salt because it can confuse you. So you can opt out of it. We actually, when you do cell-free DNA and take the DNA, the NIPT out of the mother's blood, they will ask you, do you want them to look for microarray? We try to opt out of it because it can have a lot of false positives and false negatives. So first trimester, second trimester detection of trisomy, if you're just going to look at an ultrasound and maternal age 9, I'm just going to check over 35 and just do ultrasound. You'll only detect 30% of Down syndrome. If you're really very good and you're doing the marker ultrasound like Dr. Khurana would do, you would detect probably more than 50%, maybe even up to 70. But generally speaking, the run-of-the-mill ultrasound doctor will only detect 30%. And if you check the age and you do this triple hormonal screen, it'll only detect 60%. Quadruple screen will only detect 75%. You want to be better. You want to be over 90%. So here it is. If you're doing the first trimester with the NT, you will first trimester ultrasound only. So see how much better it is, just an ultrasound, nothing else. 83% Down syndrome screening. I'm not talking all chromosomes. Down syndrome. Screen is in red because it means we are doing it on the mom's blood. But here you're not even doing blood, just ultrasound, you can pick up 83. So if you have an increased NT, it doesn't mean 83% of Down syndrome. But what you're saying is 83% of Down syndrome pregnancies you will detect on the first trimester NT ultrasound because you're going to look at the nasal bone and all the other stuff that you're going to learn soon. If you add age and just the blood test, because you don't have an ultrasound doctor in your town, so just add the double marker, the double hormonal screen, the first trimester screen, you will detect 90%. So if nobody is doing an NT in your town, don't worry. Send off the blood test, 90% Down syndrome will be picked. If somebody is doing an NT and you can send the blood and you add the age, you will detect 94% of Downs. And so the nasal bone just adds a little bit. Nasal bone is not so magical. We look at it, but so many people don't have a nasal bone. And that's okay. Some people have small nose, some people have big nose. Not a big deal. If you can't see the nasal bone, please don't sweat over it. So NT is between that Dr. Khurana will cover. I just want to show you this also he will cover that, and this you will get the slides. Email me. Don't copy it. But depending on the size of the NT, if your NT is enlarged, anything 3 or above we consider enlarged, you have a number here. What are the chances that the baby will be alive and well? And so the first trimester screen, you do free beta HCG and you do PAPA. So if the HCG is higher and the PAPA is lower, then that baby has increased risk for Down syndrome. And normal karyotype, what would you do if you have abnormal biochemical results and a normal karyotype? So if you have a low PAPA less than 0.45 and the baby doesn't have Downs, you did an NIPT, she didn't want amnio, and there's no Down, so 99% it's not Down, but this is low. And free beta is also low, less than 0.5. She is at risk for preterm delivery, preeclampsia, IUGR, and fetal death. Should you give her baby aspirin or not? That's up in the air. Studies haven't really borne it out, but if you want to give her a baby aspirin, it won't kill anyone. Sure, you can give it to her. 10 weeks onwards. So should you do cell-free DNA? Same thing is also called NIPT on the mother. When should you do it? It has to be done after 10 weeks because early on you don't have enough fetal DNA in the maternal blood. If you do it at 8 weeks, they will say, oh, there's no fetal DNA, no fraction. If it says that there isn't, patient is 15 weeks and there isn't, then that's a worry because that increases her risk for fetal aneuploidies. But if she's less than 10 weeks and you don't, of course, less than 10 weeks, there won't be much fetal DNA. So don't do it below 10 weeks. And it will detect mostly these things: trisomy 18, 21, 13, and the XX and XY. It can detect some deletions. You can do genome sequencing, but it's not the greatest, so don't do that if you don't have any issues. So these are the tests that they will offer. When you check off the box and say yes, I want cell-free DNA or NIPT, they will ask you, do you want to look at these microdeletions, this is the DGeorge, and this is the 1p36 Prader-Willi Credo chart, and you don't have to go for these. We don't go for these. So what test should you offer? You can offer diagnostic or screening tests, ultrasound, as we talked, CBS, to look, karyotype has more than 10 million base pairs, and CMA is much, 1 kilo base pair. It's really much, much better. Now, just remember, if a baby has a soft tissue marker, majority of them will be normal. Do not worry about it. Just do the next test. And these are the markers that Dr. Khurana will be talking to you about. So what is an appropriate test? If somebody sends you, there's an echogenic focus in the heart, say, yeah, not a problem. I've seen like 15,000 of those. Most of them are going to be fine. Don't worry. But the risk goes up if there are true markers, such as an NT or such as nuchal thickness, like, the skin thickness at 18 to 20 weeks, we get it. So offer testing, if not previously offered, offer diagnostic testing. In some cases, only in some cases where there is ventriculomegaly, you may offer MRI. And if there is increased Nuchal translucency, you will offer an echo. So here is what you do. If you have an isolated, rest of the baby is perfect. Nothing wrong with the baby. If there's an increased NT, offer diagnostic testing and a fetal echo. Yes, patient can opt for NIPT, but NIPT may or may not detect every single problem. Obviously, it won't. If you have an EIF, offer NIPT or serum screen. Pilactases, majority, more than 99%, won't have a chromosome problem. Offer serum screen or NIPT, and make sure you repeat the ultrasound because that could be a sign of an impending ureteric obstruction. Choroid plexus, the same thing. You offer NIPT, serum screen, echogenic bowel, same thing. You offer NIPT and serum screen. If you have lagging long bones, screen, NIPT, everything is NIPT and screen. There are only few cases where you will jump to amniocentesis. If you have mild ventriculomegaly, that is, 11, 12 and above, then you will say, let me do an amnio, because mild ventriculomegaly is not normal. Cystic hygroma is not normal. You want to offer these two people amniocentesis or CVS. This will be CVS because cystic hygromas, you see it in first trimester, and ventriculomegaly in the second. So again, these are the points I had mentioned earlier. You're going to remember these. And this is my email. And I'm sorry if I went over my time, Renu, but this is my email. And please feel free to email me, and I will be very happy to send you these slides. I don't know how to stop share.
Yeah, there is, when you click on sharing, it will show you the option of stop share.
Okay. Yeah, you are so correct. Yes, I did stop share. Thank you very much. Thanks everyone for listening to me.
Thank you so much, Asha.
Ma'am, Asha, we have Dr. Ashok Khurana on the. Ma'am, can we hold for 5 minutes, please?
Yeah, hold, matlab?
Like we are just holding. I'm just getting Dr. Khurana in, so just give me.
Okay, so let me talk. You can get him
sure,
on.
Sure, ma'am. Sure, please.
Yeah. So I really wanted to. Can you mute yourself? Can you
Ravi,
mute
turn
yourself,
your
Ravi,
computer
please?
off of your volume.
You can hear us now.
Just mute yourself. Or okay. Thank you so much, Dr. Asha. Wow, it was mesmerizing. I have honestly never understood cytogenetics so well. And something now, one thing I'm absolutely clear as a primary obstetrician, I'm not a fetal medicine expert, is that why do you do microarray and why don't you do nowadays karyotype? So I hope that message has gone clear to others too, because I have really understood for the first time. Thank you so much. And because it is important, to like she said, I would reiterate that when you are doing any prenatal testing, you better know how to interpret the results and what to counsel. I mean, you should know at least basic counseling, and then of course you should know when to refer to a fetal medicine expert. So I think because we are in an era where antenatal care, at least 30% of it, or initially almost 90% till the second trimester, revolves around doing, making a prenatal diagnosis or making sure that the baby is normal. That's our major focus in the first 2 trimesters. Later on, we start talking about fetal growth and weight and mode of delivery. But till 20 weeks, our primary concern usually is to rule out a fetal abnormality. And we, even as primary obstetricians, need to know how to screen, when to screen, and when to interpret. I mean, gone are the days when women used to deliver after 9 months, a monstrous babies, a gross abnormality, and then they were either, worshipped as God or called demons. So we nobody is going to excuse us if we do not have our basics. In these times, we need to know that. So as soon as Dr. Khurana comes on, I'm going to introduce him, but I cannot see him there. Okay. If there is any question to Dr. Asha, maybe we can utilize this time. And let me see the chat box.
So, what if the second trimester ultrasound yields prominent ventricles? So 9 millimeters is prominent. So I usually don't freak out the patient. But, if you have a second trimester 9 millimeters, it's sort of 10 millimeters is your gold standard. And it depends on who is measuring, how you're measuring. I have seen people measure. I had a patient day before. My sonographer told me it's 11. And when I went in, it was 7. So, it depends on how you are measuring it, because it's a cross section you have to do of the head. If the baby is a little bit turned, you're going to get it wrong. So I usually go in and I scan myself. I scan all my patients myself after my technician has finished scanning, only for the important stuff if they think there's wrong. But if it is 9 millimeters, I feel a little queasy, like, yeah, it's supposed to be normal, but it's a little bit too much. So in her, I would automatically offer her cell-free DNA. And I would tell her that, hey, I would reassure her. I always go in and say, hey, your baby's looking great. 9 is normal. It just looks a little prominent to me. Can you come back to me in a day or in a week or two? And then if it is truly pathological, with time, you will see it worsening. But, when you're telling her, hey, most likely it's normal, let's do, you can have cell-free DNA. I would also add, because we offer amnio to everybody, I would also offer, you know what, if you really want 100%, even if the baby is completely, totally normal, if you want to know 100%, the only way, not even 100, 99.9%, the only way is amniocentesis. If she goes for it, then if you're doing it for ventriculomegaly, you're going to get not only your chromosomes, you're going to tell them to save the fluid for microarray if your chromosomes are normal. By the way, mild ventriculomegaly is one of the markers for Down syndrome early on. So you're going to keep it, if all the chromosomes are normal, you want to do microarray. And, if the ventricles truly become more than 10, 10 and greater, then you will want to you will want to do a MRI, because when you have mild ventriculomegaly 11, 12, 13 millimeters, 99% it'll be just that, nothing else, 90% I should say. In 10%, those babies can have some learning disabilities, but that also can over time get bigger, and they can have things like many different brain issues they can have. So be sure that you're following them up. Don't give up on them, but don't freak them out. Just say, hey, let's see you back. Well, if you've done an amnio, make sure you see her back. I had just one patient that I remember who at 19, 20 weeks was mild, and I told her, just come back, and she was barely, not even 10, around 10. She came back at 22 weeks, and then it was 15, and then she came back at 24 weeks, and it was 25 millimeters. So that patient, really, that baby had a real bad issue, but otherwise they go very, very slowly. So just
Yeah.
follow them, follow them, follow them. Ideal time to order NIPT after 10 weeks starting, not before that.
Yeah, I remember, Asha, I had a patient where he was the baby was diagnosed to have ventromegaly, and everybody told them to go terminate. And then I saw her, and of course, I always get in a good ultrasonologist or somebody to guide me. But that child is now 21 years old and absolutely perfectly fine, and everybody had told them to go terminate it. He didn't have any issue at all. Okay, so I think the other question here is very general. It says, good evening, ma'am. My question is what morning advices we can give to prenatal mothers? I think I would answer that instead of you, Asha. Do not try to give unnecessary too many warnings and advices. Most people have a normal pregnancy. In fact, I tell you, it is becoming so difficult nowadays. Women are over cautious and over, for everything about pregnancy. So that doesn't help actually. That actually just makes matters worse. And another thing I would like to reiterate, like Dr. Asha said, who does the ultrasound actually makes such a difference, because most people are really not very expert in like looking at various fetal defects, and most of the, like, I have selected my ultrasonologist in South Delhi, and my husband used to say, don't take anybody's name and send, people think that you are taking a commission. I said, I don't care, because my life depends on their report. I have to counsel according to their report. So it is so important who does the ultrasound, and you need to find out really that who can actually do a good job. I think Dr. Ashok Khurana has signed in as somebody as Neha Mittal. Am I right, Ravi? I still can't see him. There is some
Yeah, ma'am, we are there. We are there. I think just give me 2 more minutes.
Okay. So maybe in the meantime, okay, but anyway, okay. So there's somebody else from Gaurang Bhatt. He's saying, Dr. Asha, thank you so much for the input, ma'am.
No, it's my pleasure. Let me just tell you one more thing. So if you have a baby with a, let's say you're seeing a VSD and the mother doesn't want an amnio, which is very common over here. Nobody wants an amnio here. It's our amnios used to be 1,000 a year, and now we do 50 a year. 50 a year. So it's gone down 20-fold. But if you're doing a cell-free DNA in her, you can get the DGeorge. You can look for the microdeletion, those 5 or 6 microdeletions that I mentioned that you can do on mother's blood in the cell-free DNA. Go ahead and order the DGeorge, because DGeorge is one of the more common conditions. If there is a genetic, most of the cardiac defects are isolated, but if there's going to be a genetic defect, it's more often it'll be DiGeorge than any of the others. Of course, if you have an AV canal defect where the mitral and tricuspid have fused and there's a single valve, it's not left side, right side. It is one single central valve that opens both the atria to both the ventricles. That if there is a chromosome problem, most of the times that will be Down syndrome. So not DiGeorge, and your NIPT will give you the result. But if you have done NIPT or cell-free DNA, whatever you call it, and you don't have any results, and it says it's normal, 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 be sure to get the DiGeorge, because DiGeorge babies have other stuff going on too. And if it's positive, then you should tell her, hey, listen, have an amnio to confirm, because I need to tell you more about what DiGeorge is going to have, what the other systems are. So,
Can I ask you more basic questions, Asha?
absolutely.
It's going all over my head what you're telling me. So let me ask you very basics, people like us who face day in and out. People do a double marker. Then there are some obstetricians who will say do a quadruple also. Does it make any sense to, if that was screen negative, should we be doing another marker? Does it make any sense?
Absolutely not. So double marker, you mean the first trimester screen,
Yeah.
right?
Yeah.
No, if you do a double marker, absolutely no place for a second trimester serum screen, because you can get two separate discordant results, and then which one are you going to believe?
Exactly.
And the poor patient, if you only don't know how to believe what are you going to tell the patient? And you can get, because there are some conditions such as severe preeclampsia. Somebody who's going to get severe preeclampsia, her HCG level is going to be elevated, not always, but high HCG level in the second trimester is associated with increased risk for preeclampsia. So let's say she's destined. I'll give you an example. I had a patient and she had a cell-free DNA at, I think, 11 weeks. So she was a 32, now she's 37. She was a 32-year-old. We published her. 32-year-old, she had a cell-free DNA at 11 weeks and it was negative. And then she came for her routine scan at 19 weeks and the baby was measuring 17. And we thought, this baby is having early onset IUGR. And so her placenta is bad. And if her placenta is bad and her hormonal levels are crazy, it doesn't just harm the placenta, it can harm the mom. So I sent off a quadruple screen on her. And the lab was refusing to do it because they said, no, she had a low risk cell-free DNA. There's no reason to do a quad screen. I said, I know that because cell-free DNA, 99%, it will pick up the Down syndrome. And so I said, I just want to know what her analytes are, this HCG, inhibin A, AFP, and estriol. So then they did it. And based on the quadruple screen, her Down syndrome risk came back as 1 in 3. And I told the patient that your quadruple screen will be positive because I think your hormones have gone bananas and it's going to harm you. So I said, we will not do an amnio because your cell-free was negative. This is just, I'm doing it for your sake.
Why did you do it then? Then why did you do that quadruple?
So the reason was just because, I'm in an academic center and residents and fellows love all these things. And even I sort of enjoyed, but her hormones were so crazy abnormal. So her HCG was more than 4 multiples of median. The inhibin A was more than 2 multiples of median. So both of these are markers for potential maternal severe preeclampsia and so on. Any placental disease. So severe IUGR, fetal death, abruption, and severe preeclampsia. And so she used to live 2.5 hours away. So I started watching her like a hawk. Sure enough, the baby wasn't growing, severe IUGR. And she delivered at 29 weeks, but the baby was like measuring, I think, 24, 25 week size. So, the thing is, you don't, but there are papers showing that there is no reason to do what I did.
Can I, on this context, can I ask you then, as a primary obstetrician, do I need to look at the separate analytes? Like suppose I do a double marker, and if it is showing screen negative, should I be bothered to look at the HCG and PAP-A separately and seeing what MOMs are there? Are you saying that?
I always look, my partners never look. And there's a
You
paper
are-
from Canada.
Are an expert. I'm asking for a basic obstetrician.
Well, I would glance at it definitely, because if it is really all wacko, then I know that the patient's health is at risk. And so then I see her, instead of saying come back in 4 weeks or 6 weeks, I will see her maybe every 2 weeks. So, but the thing is, there is no study to back me up, but I'm doing that just because I've seen so many of these cases, so many mothers getting into trouble, that I just tell them, hey, listen, during the pregnancy, I want you to see me every 2 weeks, or do your blood pressure at home. If she does a blood pressure at home, I'm fine. If not, I want to do, and then I automatically do ultrasounds every month on them, because these have been associated with placental dysfunction. Again, nothing in the literature that will say that that should be routine, but there's plenty in the literature showing that if your analytes are all funky, some analytes are associated with growth restrictions. So I say, you know what, people have ultrasounds for useless reasons. I'm going to do yours every 4 to 6 weeks to look at the growth. And so, yes, I do follow them a bit more closely.
Okay. I'm just wondering what is happening to Dr. Khurana. Is he able to log in or not? This is really becoming
I have his talk actually.
worrying.
Not his
Huh?
talk, but I have a talk on soft markers.
I would want him to
Of course,
speak.
he's the best. He's so good. I mean, I've seen his pictures. He's just brilliant,
He's
So
an
everyone,
excellent ultrasonologist.
oh, he's fantastic. He's like one of the absolute best. And yeah, I would love to listen to him. So anyway, anybody else has any questions about microarray or anything? In USA, people will not go for amnio, no matter how much. I had a lady yesterday whose baby had some, significant abnormality, and she absolutely is refusing to get anything done. She said her NT was 4.5. So she just said, no, I'm not going to, let me show you that slide of that NT,
Asha,
because
listen,
is he
Asha,
there?
no. I think I'm going to take the panel questions, which I'm going to pose to you later, because let's
Okay.
utilize the time, otherwise we'll get very late. So I'm
Okay.
going to just open my slides and not share, but I will just ask you those questions.
Okay.
Because let's utilize the time, otherwise, I don't know what's the problem. So yeah, so the question which I had put as a case, I think we may have discussed it a little bit, but you can still give a little crisp answer to that. So there is a double marker report where the Down syndrome risk is reported as 1 in 180. Can you hear me?
Yes.
So HCG is 2.12 MOM and PAP is 0.56 MOM. How would you counsel? Can you first, Asha, just 1 second. Can you please tell us, when it says HCG 2.12 MOM to a general person doesn't mean anything. What is abnormal HCG and what is abnormal PAP MOM?
So MOM is multiples of median. So they should all be 1, 1, 1, 1. Because the numbers, when you look at it, it'll be 286 picogram and nanogram and picogram. And it's like, who the heck is going to remember? So a normal person is 1.
So how much MOM is the cutoff? 1. Is it 1 for all?
No, the 1 is your normal. But when you're looking how much higher it is, so if it is, if HCG is 2 times the normal, chalta hai, no, not a problem. If it is 4 times normal, then you're like, this placenta has gone berserk and it's producing too much HCG. That has been associated with Down syndrome. That has been associated with preeclampsia, placental dysfunction. So what you do is, the way the lab will calculate, you give that same blood test to the lab and say, this blood belongs to a 20-year-old. Same blood, you say, no, this belongs to a 40-year-old. Because when they calculate it, when they calculate it, it's all these, the NT will be same no matter what maternal age. But they have different norms for different maternal age for HCG and PAPE. So they put that into the equation that age is 40,
Right.
PAPE is this, HCG is this. So her risk for Down syndrome in a 40-year-old, it'll come as 1 in 18 or 1 in 15.
Okay.
And like,
So,
oh my God, this is high risk. But a 20-year-old, her risk may be 1 in 180 or 1 in 220. So the maternal age plays a heavy role in this.
okay. So coming back to the question, how would you counsel if I see a report which says Down syndrome risk is 1 in 180?
You
What
just
do I?
tell you, so you
Yeah.
have to counsel the patient. And in the past, we used to say because amniocentesis has a risk of miscarriage. In the past, the miscarriage rate quoted used to be 1 in 200. And now, of course, we know that in experienced hands, it's much, much, much lower than that. But because 1 in 200 or 1 in 250 was considered the risk of miscarriage and amniocentesis, you tell the patient, hey, listen, your risk for Down syndrome is 1 in 180. The risk for amniocentesis related miscarriage is 1 in 200 or 1 in 250. Do you want me to do an amnio in you? So anybody whose risk used to be 1 in 200 or a higher risk than that, 1 in 80, 1 in 60, whatever, we would automatically offer them amnio. But today, we offer amnio to everyone because we know that when over here, it's only done in centers of excellence, so to speak. Of course, some private practitioners do it and they have a higher miscarriage rate. But if you do it in a center that does so many of them, the miscarriage rate can be as low as 1 in 900. So because I've done over 10,000 amnios, and so I tell the patients, if I do it, your risk is about 1 in 900 of miscarriage. Your Down syndrome risk is 1 in 180. Do you want the amnio or are you happy? Now, if her risk is 1 in 180, but the baby, she says, no, I don't want an amnio. She can
Tomorrow?
opt for cell-free DNA.
No, Sunday or maybe Sunday.
So she can opt for cell-free DNA. And if the cell-free DNA is low risk, she comes back at 19, 20 weeks.
Okay.
And we do a very detailed ultrasound exam because at least 50% up to 70% of babies will have something physically wrong on ultrasound. So if a cell-free DNA is low risk and her ultrasound is absolutely perfect, then just say, hey, your baby 99, more than 99.5% does not have it. I usually say 99.5 just because, or 99.9 if she's really young. And I say, don't worry about it. And, and if somebody really wants to know Down syndrome, she will automatically say, no, 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 do an amnio right now or do a CVS right now. If she says it, do it. So we leave it up to the patient to make a decision if she is, like if she can understand it. But if she is like, no, I don't want invasive testing, then do your cell-free DNA and then do your ultrasound. Why are you doing it at 19 weeks? So that if you see a big heavy canal defect, she can abort the pregnancy in time.
Okay. So another very simple question. You have told us, but just to get a very clear answer. So if you have a screen positive double marker, you've already actually told all that, isn't it? Yeah, that's question is answered. Okay, fine. So
I have to tell you this. Yeah, go ahead. You want me to? Somebody wants to. I want to talk about Klinefelter. This is really very interesting. It's a social thing. Can I talk for a minute on it, Renu?
okay.
So, at Johns Hopkins, I was a fellow. I was, very young. And in India, we finish med school when you're 22 and then you come to your. So I'm entering the hospital and there's this big, huge fellow in the elevator. And it was him and me standing. And, I'm about 5'3". This fellow is about 6 something, 6 feet tall. And I look up and his card, his ID, we all have to wear our IDs with our picture and the name on it. So his ID card, it's like a plasticky thing that hangs from your collar. It says Klinefelter. So I said, hi. I said, you have a very famous name. There used to be a Dr. Klinefelter and there's a Klinefelter syndrome. And it is named after the doctor. I said, would you by any chance be related to the person? And he looks down at me and he says, I am Dr. Klinefelter. And I was like, oh my God. I said, it's such an honor. So when I was at Johns Hopkins, I would meet all these gods of OBGYN, and Kelly is from there, your Kelly Clamp, and so many. Woodruff, the book that you read, Woodruff, textbook of pathology, he was there, and I would call him Dr. Woodruff, and he didn't like it, and I had to call him professor, like, okay. But so one day I was entering, Johns Hopkins is in Baltimore, which is very relatively violent city and a lot of guns and God knows nonsense. So I was entering the hospital and you can't enter without your ID. So I was entering and Kleinfelter was right just behind me with me. So the guy nicely lets me go. I have my ID and Kleinfelter had forgotten his ID at home. And this was a young, African American, like, hey, dude, where is your ID? And the fellow said, oh, I mean, sorry, I forgot to bring it. He's in his 70s or something. And this guy would not let him in. He said, nope, you can't enter. And I told him, he's Dr. Kleinfelter. And he said, I don't care who he is. I don't know who he is. I'm not going. He made him go home. He made Dr. Kleinfelter go home, who had been
All
working
right.
there for 50 years.
Okay. Okay. So, ladies and gentlemen, I have a little bad news. We have tried every trick in the book and we cannot get Dr. Ashok Khurana to log in. So I was thinking we had some questions in the panel. We wouldn't do the whole talk because it's already 8:10, but we had some questions and maybe Dr. Asha can take them because these are very common scenarios which I had put for the panel discussion. Things which obstetricians see day to day and, we need to deal with them. So basic counseling. So can you give me some crisp answers to my questions, please?
Yes,
Yes, I will
Renu
just.
knows me too well.
Okay. You are so bubbling with knowledge that it's difficult to make it crisp, isn't it? Okay. So,
No, just experience. Go
yeah.
ahead.
All right. So these were questions actually meant for Dr. Ashok Khurana. So this is, the first one is about NT. So the first trimester screening is done and the NT scan is showing 12 weeks and 5 days and NT is 2.1. How do you counsel?
12 weeks and 5 days and the NT is 2.1.
2.1.
कोई प्रॉब्लम नहीं यार एकदम अच्छी एंटी है उसमें क्या प्रॉब्लम है I use a millimeters of 3 if it is even my technicians here they will go and they want all this calculation I said काय के लिए यार खराब कर रही है दिमाग अपना भी मेरा भी
So
they have this stupid package
NT would you be worried?
अरे 3 होगा और उसके ऊपर then worry under 3 stop all that stupid calculation not worth your time.
All right. What if you don't see the nasal bone? I know you talked in this your lecture, but just tell us once again. If you don't see the nasal bone, what do you do?
So if you don't see a nasal bone, you say, hey, you must be Indian. So Indian people, 4 to 5% of babies don't have nasal bone in utero. And in Caucasians, it's about 2%. In Asians, like Chinese, Japanese, it is more like 6-7%. So nasal bone absence is just one little bit on your plate. So
what
take
do
it
you
with
do?
a grain of salt. Orders NIPT on them. NIPT, aram se sab. I order NIPT on everyone. I don't do this hormonal things unless
fine.
it's perfect.
Right. Okay. So then we're coming to more ultrasound related questions.
Can I show one slide? I just want to share one slide. Is it possible?
Sure, ma'am. I'll just give you the rights.
Give me the right. Yeah. So
Just hold on.
can you see me?
Yes, but we can't see your screen.
तो मैं कैसे screen को how do I share? Oh yeah, got it. I see it. Yeah, I see it. Thank you. So here it is. Let me share this. So just remember that you are doing NT between 11 and 13 and 6/7 weeks. The crown rump length has to be 45 to 84. As you know, ultrasound has its plus minus, right? So at 11 weeks, it may say 43 millimeters. Then guess what? You cannot do your double screen because that lab result wants minimum crown rump of 45. I usually do my NTs at 12 weeks. So that plus minus nahi hota hai because it is plus minus 5 days, right? That's the normal variation. So I do it at 12 weeks. And then if yeah, so here is your NT. You will get this if you email me. or take a picture of this with your thing.
Yeah.
So
People will.
I have this I have this on my cell phone. If the NT, this is all 3 millimeter. This is 3 millimeters or greater, 95 to 90, 3 to 3.5 millimeter. So if you look at your NT and then you say, okay, the risk for chromosomal abnormality is this much. If your NT is 3.4, chromosomal abnormality is 3.7%. Anything more than 3, it is elevated. If it's less than that, like 0.2, her risk is 0.2. In that case, offer her NIPT. And then if it is higher, 6.5, then you're like, okay, this really looks terribly bad. And then how many of these children will be alive and well? So if you have an NT of 3 millimeters, 93% of those babies will be alive and well. Why? Because some of those babies will have a major birth defect. So do an echo on all of these, because heart defects show up. 25% of all cardiac defects show up as increased NT in the first trimester, 25%. If you have a woman with an increased NT, her chance, and a normal chromosome, normal, her chance of having a baby with a heart defect is only about 3%. So 3% of all NTs will have a heart defect, but of all the heart defects, 25% will have an increased NT. So NT is a good thing to do, but here is your major abnormalities here. So Renu, here is where your baby falls. Under 95th centile, chromosome risk is only 0.2%. Fetal death, by the way, is increase NT. And so, 1.6%, all the babies, that's the background risk of birth defects. And that kabhi gastroschisis hai, kabhi omphalocele, sometimes extra finger, blah, blah. So background risk for birth defect is about 2%. So this is what I use very, very religiously. I'm very, very, I carry this on my cell phone so I can whip it up and show it to a patient like here it is. So I do not tell them what to do. I tell them, you want NIPT? And I'll ask them, do you want NIPT? Because I feel in my heart, amnio should not, she's 22, why do an amnio? But she will make the final decision. She wants an amnio, hey, I'll do it. But most of our patients don't want an amnio. No more.
If she's 37?
37-year-old hoker be that that the lab will do the calculation. Oh, I did not show this, did I? Let me show you. This is a big secret that nobody knows. Abhi main kahan se ye secret batao? I don't know how to show you, but there is something called, it's on my cell phone. There is a calculator. Renu, I will share that calculator with you in the email. But there's a calculator, and if you do an NIPT, if you do an NIPT and then you put her age and everything, the calculator will tell you what her risk is of having a baby. Give me a number and I will do this for you and I'll show it to you.
Okay, I think you can email to me, and then I think we will have another day, maybe get Dr. Ashok Khurana in, and we can show that calculator on that day.
It's a really brilliant calculator. So like it's a perinatology, it's by the genetics counselors in the USA. They have come up with this. But for example, you said that her she's 37, did you say?
Yeah.
So what is a positive predictive calculator? So the chromosome, let's say we are looking for trisomy 21 and the mother's age at due date is 37. Then you put this in the calculator and then you want to know what is the positive predictive value and you calculate, and her positive predictive value of the baby having Down syndrome is 86%. False positive is 14%. So you'll tell her, listen.
So we still need it.
हाँ, amnio फिर भी करना पड़ता है. And I'll just tell you, there's one, ये किधर गुम हो जाता है यार? I can never find this thing. I don't know why I'm losing that.
It's okay. It's okay. We will refer her to you rather than doing this ourselves.
नहीं, but I lost you. मैं देख ही नहीं पा रही हूँ ये WebEx. पता नहीं कहाँ पर चला गया.
वो नीचे चला गया. It's okay. We can see you. अच्छा.
Okay,
one last question. Among the list which I had kept for panel questions. So we have already actually covered most of the things. Like ventriculomegaly, you've already told us. What about pilectasis? If you find pilectasis on your anomaly scan, how do you counsel?
So pilectasis is very common and we see 1 or 2 every day. So this is what I tell patients. Hey, your baby looks great. You know, your baby's renal pilectasis is 4 millimeters or greater, not less. 3.5 is not. 4 or greater. I'll say, hey, your baby's is 4.3. That's normal in most cases. 90% will be normal. There's about a 10% chance your baby may have some reflux. And so I need to see your baby back just to be sure it doesn't have a reflux, because ureteric reflux in a newborn can cause UTI and UTI related sepsis. Rarely, very, very rarely, it can be a ureteric obstruction. And so when you come back, we'll look at that, but I wouldn't worry about ureteric obstruction because 90% is going to go away. Don't you worry about it. Oh, by the way, there's a slight risk of chromosome problem. Do you want NIPT? If she has it, good. That's good. Chances are 99.9% your baby doesn't have Down syndrome. But if you want amnio, I can do it. And they'll say, no, thank you. But I do offer NIPT to those people.
So basically what you're saying, NIPT and follow-up ultrasounds.
That's correct.
Right?
Follow-up is critical because when I was in India, some neighbor said, ki ye bacha 14 ka and the kidney failure. I said, what happened? They said, oh, don't know. And then they realized that this kid had ureteric had pilectasis, never followed up in utero, and nobody checked it at birth, and then UTIs, and then now 14 years kidney. That was terrible. I felt really bad for the kid.
You said 10% can have chromosomal defects. Is it right?
No, very less than 1%.
Less than
10%
okay.
can have ureteric reflux.
Okay, right. So so less than 1% will have chromosomal defects, which you can rule out on NIPT. And if
99%, 99%,
yeah, I mean, if she wants 100%, then we do a amnio.
Yeah.
Okay.
But till today, I have never had any patient wanting an amnio for pilectasis.
You know, it depends, because I think that way Indians nowadays are much more sort of fussed. You know, they want to be sure, absolutely sure.
Then get me a job there, na, because I'm very much suffering lack of amniosis. मेरे को इतनी आदत थी टक 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 टक, and now nobody wants an amnio.
Okay. I think there are no more questions, Asha. And
okay, one question I want to say.
Yeah.
Somebody has sent me an email. I cannot copy your email from the chat. So if you email me, I will email you back. But otherwise, I cannot.
Yeah. Okay. No, that is Volta Kluwer saying provide feedback. That's not for you.
No, somebody has sent a message. Okay, please email me the PowerPoint. But the thing is, I can't copy paste it from the chat box. Okay. So if you want it, email me.
Send it to me and I can share it with them.
Yes, Renu, do that for me. It was so lovely to see you. I love you, Renu. And thank you, everyone, for joining. Hope to see you soon again.
Thank you very much. And extremely sorry that Dr. Khurana could not join. And I'm hoping that maybe we can, he's a busy man. His weekend is very, very all busy with webinars, but maybe we can next week. Ravi, are you here? Can you hear me?
Yes, ma'am. We are very much here.
Maybe next week we can find a convenient day for him and we can see his slides, because his ultrasounds are really beautiful. It's a joy to see his ultrasounds. So I think on that note, I would really thank Dr. Asha for joining us early in the morning. It is always such a pleasure to hear you and your stories, and you make things so clear. You are really a great teacher. And but I think we could go on and on with you actually, but I think for constraints of time, we will have to stop here and hope to see you again with some more fresh knowledge. And good night, Dr. Asha.
Good night. Thank you. It was it's always a fantastic, for me, I love to work with you. So thank you so much for inviting me. I really enjoy you. I think you're one of the most brilliant people.
Good night, everybody, all the panelists. And good day to you, Dr. Asha. And for our technical support, Mr. Ravi Shukla, thank you very much. So let us hope we can do the rest of the webinar next week sometime. Thank you.
Thank you so much. I thank all my panelists and attendees, and I really apologize on behalf of Walter Kluwer that due to technical difficulties, Dr. Ashok could not join us today. But very soon, maybe by next week, we'll have another session on the same topic, and we'll have Dr. Ashok because, as Dr. Renu said, his ultrasounds are very good. So I think we should have a look at them. So let's try to meet next week, and I'll send the link to each one of you. Thank
And
you
if
so much.
Dr. Aksha is free, then we can ask her to join again also.
Sure, ma'am.
Yeah.
Thank you.
Thank you.